We will cover heart failure in this video. Heart failure is often referred to as congestive heart failure. It is the inability of the heart to pump sufficient blood to meet the needs of the tissue for oxygen and nutrients. However, the term congestive heart failure is misleading because it indicates that patients must experience pulmonary or peripheral congestion to have heart failure, and it implies that patients with congestion should have heart failure. The heart failure guidelines panel use the term heart failure because many patients with heart failure do not manifest pulmonary or systemic congestion. The term heart failure is preferred and indicates myocardial heart disease in which there is a problem with the contraction of the heart or filling of the heart and which may or may not cause pulmonary or systemic congestion. Heart failure means that the heart is unable to pump blood around the body properly. It usually happens because the heart has become too weak or stiff. Heart failure guidelines panel define heart failure as a clinical syndrome characterized by signs and symptoms of fluid overload or of inadequate tissue perfusion. These signs and symptoms result when the heart is unable to generate a cardiac output sufficient to meet the body's demands. Some cases of heart failure are reversible depending on the cause. Most often, heart failure is a lifelong diagnosis that is managed with lifestyle changes and medications to prevent acute congestive episodes. Congestive heart failure is usually an acute presentation of heart failure. Now we will see the etiology of heart failure. Hypertension and coronary artery disease are the primary risk factors for heart failure. Hypertension is a modifiable risk factor that should be aggressively treated and managed. Long-term treatment of hypertension reduces the incidence of heart failure by 50%. Comorbidities such as diabetes, metabolic syndrome, advanced age, tobacco use, and vascular diseases contribute to the development of heart failure. In medicine, comorbidity refers to the simultaneous presence of two or more medical conditions in a patient after co-occurring with a primary condition. Other causes of heart failure include congenital abnormalities, infiltrative cardiomyopathies, infections, and inflammatory processes, persistent dysarrhythmias such as ventricular dysarrhythmias, atrial dysarrhythmias, and toxins such as use of cardiotoxic drugs, chemotherapy. Any interference with the normal mechanisms regulating cardiac output may cause heart failure. Cardiac output depends on preload, afterload, myocardial contractility, and heart rate. These factors affect stroke volume, which is the amount of blood pumped per heartbeat. Any changes in these factors can lead to decreased ventricular function and heart failure. The major causes of heart failure are divided into primary causes and precipitating causes. Precipitating causes increase the workload of the heart, causing acutely decreased heart function. Now we will see what are the primary causes of heart failure. Myocardial dysfunction is most often caused by coronary artery disease, including myocardial infarction, cardiomyopathy, hypertension, including hypertensive crisis, or valvular disorders such as mitral stenosis. Atherosclerosis of coronary artery is another primary cause of heart failure. Other primary causes include congenital heart defects such as ventricular septal defect, hyperthyroidism, myocarditis, especially post-viral myocarditis, which can cause heart failure. Pulmonary hypertension, rheumatic heart diseases. These are the primary causes of heart failure. Now we will see the precipitating causes of heart failure. Anemia. Decreased oxygen carrying capacity of the blood stimulating increase in cardiac output to meet tissue demands, leading to increase in cardiac output and increase in size of left ventricles. Thus leads to heart failure. Bacterial infection increases metabolic demands and oxygen requirements, especially endocarditis, which cause valve dysfunction, causes stenosis or regurgitation of valves. Next precipitating cause is dysarrhythmias. It may decrease cardiac output and increase workload and oxygen requirements of myocardial tissue. Fluid overload. It increases preload, causing volume overload on the right ventricle. Hypothyroidism indirectly predisposes to increased atherosclerosis. Severe hypothyroidism decreases the myocardial contractility. Any viral, bacterial, or any other type of infection can increase oxygen demand of tissues, stimulating increased cardiac output. Nutritional deficiencies may decrease cardiac function by increasing myocardial muscle mass and myocardial contractility. Obstructive sleep apnea, frequent nighttime apnea results in increased afterload, intermittent hypoxia, and increased sympathetic nervous system activity. Paget's disease. It increases workload of the heart by increasing vascular bed in the skeletal muscle. Paget's disease of a bone disturbs the normal cycle of a bone renewal, causing bones to become weakened and possibly deformed. Pulmonary embolism increases pulmonary pressure resulting from obstruction, leads to pulmonary hypertension and decreased cardiac output. Thyrotoxicosis changes the tissue metabolic rate, increases heart rate and workload of the heart. Other risk factors include hyperlipidemia, family history of heart failure. Now we will see the pathophysiology of heart failure. Heart failure results from a variety of cardiovascular disease which leads to common heart abnormalities that results in decreased contraction, that is called systolic heart failure, decreased filling, that is called diastolic heart failure, or it can be both. In systolic heart failure, the amount of blood ejected from the ventricles are decreased, which stimulates the sympathetic nervous system to release epinephrine and norepinephrine. The purpose of this initial response is to support the failing myocardium, but the continued response causes loss of beta-1 adrenergic receptor sites and further damage to the heart muscle cells. The sympathetic stimulation and the decrease in renal perfusion by the failing heart causes the release of renin by the kidney. Here, the renin-angiotensin-aldosterone system works. The renin promotes the formation of angiotensin 1. It is a benign, inactive substance. Then, the angiotensin-converting enzyme in the lumen of blood vessels converts angiotensin 1 to angiotensin 2. It is a vasoconstrictor that also causes the release of aldosterone. Aldosterone promotes sodium and fluid retention and stimulates the thirst center. Aldosterone causes additional detrimental effects to the myocardium and exacerbate myocardial fibrosis. Angiotensin, aldosterone, and other neurohormones such as atrial natriuretic factor, endothelin, and prostacyclin lead to an increase in preload and afterload, which increases stress on the ventricular wall, causing an increase in the workload of the heart. As the heart's workload increases, contractility of the myofibrils decreases. Decreased contractility results in an increase in end diastolic blood volume in the ventricles, stretching the myofibers and increasing the size of the ventricles, causing ventricular dilation. The increased size of the ventricles further increases the stress on the ventricular wall, adding to the workload of the heart. One way the heart compensates for the increased workload is to increase the thickness of the heart muscle, called ventricular hypertrophy. However, the hypertrophy is not accompanied by an adequate increase in capillary blood supply. Because of that, it results in myocardial ischemia. Eventually, the myocardial ischemia causes myofiber death even in patients with coronary artery disease. The compensatory mechanism of heart failure have been called the vicious cycle of heart failure because the heart does not pump sufficient blood to the body, which causes the body to stimulate the heart to work harder. But the heart is unable to respond and failure becomes worse. Diastolic heart failure develops because of continued increased workload on the heart, which responds by increasing the number and the size of myocardial cells, that is called ventricular hypertrophy, and also have altered myocellular functioning. These responses causes resistance to ventricular filling, which increases ventricular filling pressure despite a normal or reduced blood volume. Less blood in the ventricles causes decreased cardiac output. The low cardiac output and high ventricular filling pressure causes the same neurohormonal responses as already described for systolic heart failure. Ischemia causes myocardial dysfunction because of resulting hypoxia and acidosis from the accumulation of lactic acid. Myocardial infarction causes focal heart muscle necrosis and death of heart muscle cells and a loss of contractility. The extent of the infarction correlates with the severity of heart failure. Significant myocardial dysfunction most often occurs before the patient experiences signs and symptoms of heart failure. Cardiac compensatory mechanisms like increasing the heart rate, vasoconstriction, heart enlargement initially occurs to assist the struggling heart. These mechanisms are able to compensate for the heart's inability to pump effectively and maintain sufficient blood flow to organs and tissue at rest. Physiological stresses that increase the workload of the heart, like exercise, infection, may cause these mechanisms to fail and precipitate the clinical syndrome associated with a failing heart, such as elevated ventricular or atrial pressures, sodium and water retention, decreased cardiac output, circulatory and pulmonary congestion. The compensatory mechanism may sometimes hasten the onset of failure because they increase afterload and cardiac work, mainly caused by disorders of heart muscle resulting in decreased contractile properties of the heart, such as coronary artery disease, hypertension, dilated cardiomyopathy, and valvular heart disease. Heart failure is a clinical syndrome that results from the progressive process of remodeling in which mechanical and biochemical forces alter the size, shape, and function of the ventricle's ability to fill with or pump enough oxygenated blood to meet the metabolic demands of the body. There are two types of dysfunction that may exist with heart failure. They are systolic versus diastolic failure, acute versus chronic heart failure. In systolic heart failure, poor contractility of the myocardium results in decreased cardiac output and an elevated systemic vascular resistance. In diastolic failure, stiff myocardium, which impairs the ability of the left ventricle to fill up with blood. This causes an increase in pressure in the left atrium and pulmonary vasculature, causing the pulmonary signs of heart failure. Acute failure occurs with the sudden onset of symptoms such as acute pulmonary edema and decreased cardiac output, requires intervention and medical attention. In chronic failure, long-term process with accompanying compensatory mechanisms can progress to acute phase in the setting of dysarrhythmias, ischemia, or sudden illness. Stages of heart failure. There are 4 stages of heart failure. These 4 stages help cardiologists determine how serious the condition is and what kind of treatment the patient needs. Stage A heart failure. People with stage A heart failure do not yet have problems with their heart's pumping action, but they are at high risk of developing heart failure due to linked disorders. Conditions to consider include chronic high blood pressure, diabetes, and coronary artery disease. At this stage, a person normally has no heart failure symptoms, but they may have symptoms from other chronic diseases. People with this stage of heart failure have no problems with the structure of their hearts or how they function. The goal of treatment should be to manage risk factors. Stage B heart failure. At this stage, structural heart disease develop, such as decreased heart pumping and an enlarged left ventricle. It may also result from a previous heart attack. The majority of people in stage B still do not develop heart failure symptoms. A doctor may give medicines at this point to help manage and prevent future problems. Stage C heart failure. At this stage, people start to show symptoms of heart failure associated with underlying structural heart disease such as exhaustion or shortness of breath. These symptoms are mainly caused by difficulties with the left ventricle's squeezing function or the pumping chamber of the heart. Some common symptoms may include fatigue, breathlessness, difficulty breathing, lower extremity edema, rapid weight gain, abdominal distension. Stage D heart failure. People in stage D heart failure will have extensive structural heart diseases and experience considerable symptoms even while they are at rest. Some common symptoms may include shortness of breath, difficulty breathing, swelling of legs, arms, hands and ankles, fatigue, nausea, rapid heartbeat, lightheadedness, persistent cough. What are the types of heart failure? There are 4 types of heart failure. Right-sided heart failure. This type affects the lower right heart chamber called the right ventricle. Fluid may back up into the belly, legs, feet, causing swelling. Next is left-sided heart failure. This type affects the lower left chamber called the left ventricle. Fluid may back up in the lungs causing shortness of breath. Next type is heart failure with reduced ejection fraction, also called systolic heart failure. This is a type of left-sided heart failure. The left ventricle can't squeeze as strong as it should. The heart isn't strong enough to pump enough blood to the body. Next type is heart failure with preserved ejection fraction, also called diastolic heart failure. This is a type of left-sided heart failure. The left ventricle can't relax or fill fully. The heart has trouble filling with blood. The symptoms may develop slowly. Sometimes heart failure symptoms start suddenly. Initially, there may be isolated left-sided heart failure, but eventually the right ventricle fails because of the additional workload. Combined left and right-sided heart failure is common. Clinical manifestations of left-sided heart failure. Altering the filling and pumping function of left ventricle, congestion occurs mainly in the lungs from blood backing up into the pulmonary veins and capillaries. Patients may have shortness of breath, dyspnea on exertion, tachypnea, paroxysmal nocturnal dyspnea, that is due to reabsorption of dependent edema that has developed during the day. Patient may have orthopnea, cyanosis, pulmonary edema, and hemoptysis. Patient may have cough, may be dry, unproductive, usually occurs at night. Fatigability from low cardiac output, nocturia, insomnia, dyspnea. Catabolic effect of chronic failure. Patient may have restlessness, tachycardia, S3 and S4 sound may be heard. Signs and symptoms of right-sided heart failure. Altering the pumping function of right ventricle, there are signs and symptoms of elevated pressures and congestion in systemic veins and capillaries. Patient may have edema of ankles and unexplained weight gain. Liver congestion. It may produce upper abdominal pain, distended jugular veins, increased CVP, pulmonary hypertension, abnormal fluid in body cavities like pleural space and abdominal cavity. Patient may have splenomegaly, anorexia, and nausea from hepatic and visceral engorgement. Nocturia, diuresis occurs at night with the supine position and improved cardiac output. Common cardiovascular findings in both types are cardiomegaly, that is enlargement of the heart detected by physical examination and chest x-ray. Ventricular gallop, that is evident on auscultation, rapid heart rate, development of pulses alternates. How to diagnose heart failure? Echocardiography. Two-dimensional with the Doppler flow studies may show ventricular hypertrophy, dilation of chambers, and abnormal wall motion. And also it helps to detect valvular disease and ejection fraction. Measurement of pulmonary artery wedge pressure by Swan-Ganz catheter. It differentiates etiology of pulmonary edema to find out whether it is caused by cardiogenic or altered alveolar capillary membrane. ECG is taken during resting and exercise, may show ventricular hypertrophy and ischemia. Chest X-ray may show cardiomegaly, pleural effusion, and vascular congestion, and also it shows interstitial edema. Cardiac catheterization. Left heart catheterization is to rule out coronary artery disease. Right-sided heart catheterization to measure pulmonary pressure and left ventricular function. Next test is a radionuclide ventriculogram. It is a non-invasive way of assessing the ventricular function and intracardiac hemodynamics. Next test is a thallium scan to rule out underlying causes. Thoracentesis fluid sample is taken for diagnosis and treatment. ABG studies may show hypoxemia due to pulmonary vascular congestion, and also it show impending respiratory failure. Blood work such as CBC, electrolytes, calcium, magnesium, renal function, glycohemoglobin, lipid profile, thyroid function, and liver function studies to fully assess patient condition that may impact heart failure. Blood cultures are done in suspected infection. It may be positive. Cardiac marker test is done in suspected MI. It may be elevated. As volume and pressure in the cardiac chambers rise, cardiac cells produce and release more cardiac markers like BNP, that is human B type natriuretic peptide. This test aids in the differentiation of heart failure from other pulmonary heart failure due to systolic and diastolic dysfunction. BNP is used in the emergency department to quickly diagnose and start treatment. Now we will see the management. The management is based on stages. Stage A, it is especially focuses on eliminating the risk factors by initiating the rapid lifestyle changes such as smoking cessation, increasing physical activity, and decreasing alcohol consumption. This stage also focuses on controlling chronic diseases such as hypertension, high cholesterol, and diabetes. Beta-adrenergic blockage, ACE inhibitors, and diuretics are useful in treating this stage. Stage B treatment is similar to Stage A treatment with emphasis on use of ACE inhibitors and beta-adrenergic blockers. Stage C treatment is the same as Stage A and Stage B but with closer surveillance and follow-up. The immediate objective of Stage C treatment is to improve oxygenation and reduce pulmonary congestion. Identification and correction of precipitating factors and underlying conditions are then necessary to prevent recurrence. Increasing oxygen tension by giving oxygen therapy. High concentrations of oxygen are used to combat hypoxemia. Intubation and or ventilator support may be necessary to improve hypoxemia and prevent hypercarbia. Glycoside such as digoxin is typically added to the treatment plan in this stage to improve the heart's ability to pump effectively. Beta agonists also are used to improve the heart's ability to pump effectively. Reduce the fluid volume by giving diuretics. Use of hydralazine, nitrate, aldosterone antagonist, vasodilators as indicated. anti-anxiety drug to reduce the anxiety. These all guide therapeutic interventions. Drug classes to be avoided due to worsening of heart failure symptoms include antiarrhythmic agents, calcium channel blockers, and NSAIDs. In stage D, the patient may need mechanical circulatory support, continuous ionotropic therapy, cardiac transplantation, or palliative care. The aim of treatment is to reduce excess body fluid. The patient may not tolerate other classes of drugs used in previous stages. Drug classes include diuretics. The diuretics are given to reduce the preload, eliminate excess body fluid, and decrease ventricular pressure. A low sodium diet and fluid restriction complement this therapy. Some diuretics may have slight venodilator properties. Spironolactone is most commonly used. It is a diuretic that treats high blood pressure and heart failure. It can also reduce swelling related to heart, kidney, or liver diseases. It helps kidneys to remove more fluid and salt from blood through urine without losing too much potassium. Positive ionotropic agents are used to increase the heart's ability to pump more effectively by improving the contractile force of the muscle. Contractility enhancement therapy include digoxin, dobutamine, neseritide, milrinone. This improves the ability of the heart muscle to pump more effectively, allowing for complete emptying of blood from the ventricle and a subsequent decrease in fluid backing up into the lungs. Dopamine improves renal blood flow and urine output. Dobutamine stimulates heart muscle and improves blood flow by helping the heart pump better. Neseritide decreases pulmonary artery pressure. It used in patients with decompensated heart failure. It produces smooth muscle cell relaxation and diuresis and a reduction in afterload and dyspnea. Milrinone and amrinone are potent vasodilators and increase contractility. Digoxin may be initiated at any time to reduce symptoms of heart failure, prevent hospitalization, control rhythm, and improve exercise tolerance. Morphine is analgesic of choice because it enhances peripheral dilation, decrease venous return, and decrease anxiety, thus decreasing workload of the heart. Vasodilator therapy helps dilating peripheral vessels, reduce the amount of blood returning to the heart, and resistance against which the heart must pump, thus decrease the workload of the heart. By relaxing capacitance vessels, that is veins and venules, vasodilators reduce ventricular filling pressures, that is preload, and volumes. By relaxing resistance vessels, that is arterioles, vasodilators can reduce impedance to left ventricular ejection and improve stroke volume. Nitrates are used. It is a preload reducers such as nitroglycerin, isosorbate, nitroglycerin ointment. Predominant dilate systemic veins. Use extreme caution in administering nitroglycerin to patients with aortic stenosis who are preload dependent. Hydralazine is a medication used to treat high blood pressure and heart failure. It predominantly affects arterioles, reduces arteriolar tone. Prazosin works by relaxing the blood vessels so that the blood passes through them more easily. It balances effects on both arterial and venous circulation. Sodium nitroprazide is an afterload reducer. It predominantly affects arterioles. Aminophylline may prevent bronchospasm associated with pulmonary congestion, but it should be used with caution because it may also increase heart rate and induce tachydysarrhythmias. ACE inhibitors are used. It helps inhibit the formation of angiotensin. In doing so, it produces vasodilation, and also it prevents ventricular remodeling with chronic use. ACE inhibitors can alleviate heart failure symptoms and clinical status as well as overall sense of well-being among heart failure patients. Examples are captopril, enalapril, lisinopril. Beta-adrenergic blockades are negative ionotropes that decreases myocardial workload and protect against fatal dysarrhythmias by blocking norepinephrine effects of the sympathetic nervous system. Metoprolol or metoprolol sustained release are commonly used. Carvedilol is a non-selective beta and alpha adrenergic blockage. Patients may actually experience increase in general malaise for a 2 to 3 week period while they adjust to the medication. Angiotensin II receptor blockades are similar effects as ACE inhibitors, although mechanism of action is different. Used in patients who cannot tolerate ACE inhibitors due to cough or angioedema. Examples are valsartan, losartan. Aldosterone antagonist decreases sodium retention, sympathetic nervous system activation, and cardiac remodeling. May cause hyperkalemia, especially in those with impaired renal function, in those taking high doses of ACE inhibitors, or in those who use potassium supplements. Assess patients' risk for hyperkalemia when administering aldosterone antagonist. Amiodarone is a drug used to treat arrhythmias. Restrict fluid and sodium intake. Mechanical circulatory support may be used in stage D, heart failure and acute exacerbation of heart failure. Intra-aortic balloon pump is a mechanical device that increases myocardial oxygen perfusion and indirectly increases cardiac output and decreases afterload and improve coronary blood flow. Cardiac resynchronization therapy or biventricular pacing helps to restore synchronous ventricular contractions, improves left ventricular filling, and improves cardiac output. Partial left ventriculectomy or reduction ventriculoplasty or Batista procedure are done. A triangular section of the weakened heart muscle is removed to reduce ventricular wall tension. This procedure is not commonly used. Endoventricular circular patchplasty or the DOR procedure is a removal of diseased portion of a septum or left ventricle with a synthetic or autologous tissue patch, thus providing a more normal shape and size of the heart, which improves hemodynamics. A cone cardiac support device is a polyester mesh custom fitted jacket is surgically placed on the epicardial surface, providing diastolic support. Over time, it decreases or halts remodeling. Intubate the patient if the patient is having respiratory distress. An implantable cardioverter defibrillator are used for patients with previous cardiac arrest, sustained ventricular arrhythmias, and in those post-MI with ejection fraction less than 30%. Heart transplant or a cardiac transplant is a surgical transplant procedure is performed on patients with end-stage heart failure or severe coronary artery disease when other medical or surgical treatments have failed. What are the complications of heart failure? Intractable or refractory heart failure. That means it becomes progressively refractory to therapy. That means it does not yield to therapy. Cardiac arrhythmias, myocardial failure and cardiac arrest, digoxin toxicity from decreased renal function and potassium depletion, pulmonary infection, pneumonia, and emboli.